Hello everyone, my name is Rafiq Kandi. I'm a lead sleep technologist working here in Cleveland Clinics, Abu Dhabi. Today we will be discussing about the PAP titration guidelines for those who diagnosed with obstructive sleep apnea. Before we go deep into the titration guidelines, let's have some questions. What is the difference between obstructive apnea and obstructive sleep apnea? Obstructive apnea is a single event where there is no flow with a continued effort for more than 10 seconds in adults, whereas obstructive sleep apnea is a disorder diagnosed by a sleep physician. It may include obstructive apnea, hypopneas, mixed apneas, and sometimes a few central apneas. So whenever I say in this presentation obstructive apnea, it means to a single event and sleep apnea as a diagnosis. So now the question is, what is the diagnostic criteria for obstructive sleep apnea? I'm sure that by this time you might have completed or you are familiar with the sleep disorders and its classifications and the polysomnography, how to perform it, and different types of the sleep studies, how to score the sleep stages, how to score respiratory events, and lip movement, etc. So, according to the ICSD criteria, there are different criteria to meet it to call it an obstructive sleep apnea. There is some slight differences between ICSD 2005 guidelines, 2015 versus the ICSD 3 TR version, which published last June. So, according to ICSD TR, there is the criteria includes A and B or C plus D must be matched to call it as an obstructive sleep apnea. A, what is the A? This is the presence of the symptoms like fatigue, insomnia, excessive daytime sleepiness, witnessed apneas, gasping, choking, or bed partner um, or other observer reporting the habitual snoring. And B, which includes a PSG or a home sleep study showing a HI of more than 5 or REI of more than 5, predominantly of obstructive respiratory events, which includes obstructive apneas, mixed apneas, hypopneas, regulars. Or C, which is a PSG or home sleep studies, which shows a 15 or more predominantly obstructive respiratory events per hour of sleep. And the D, which is the new addition, which is the symptoms are not better explained by another current sleep disorder, medical disorder, or medication or substance use. And we know that, so what is the diagnostic severity classifications in adult? It is mild, is considered to be something about the 5 to 15 AHI, moderate 15 to 30, and more than 30 is considered to be severe. And for the children less than 12 years age is also shown here, 1 to 5, 5 to 10, and greater than 10. And you may be hearing that the AHI is not only the severity classification, but which is not the purpose of this discussion. So we'll be discussing mainly on the titration guidelines. So what are the treatment options when you have been diagnosed or somebody is diagnosed with obstructive sleep apnea? As I said during the sleep disorder discussions, it has been discussed about the weight management, surgical options, CPAP, lifestyle changes, or positional therapies. So many changes, mandibular advancement devices, etc. Today we will be discussing about only on the CPAP titration side. There are two types of treatment, either with a home CPAP titration or an auto CPAP titration versus in-lab manual titrations. What type of the titration is to be used is upon based on your lab protocol or your physician's discretion. So here we will be mainly discussing about the in-lab manual titrations guidelines. So now we know that there are different types of the sleep studies. One is diagnostic polysomnogram, or a PAP titration polysomnogram, split night polysomnogram, MSLTs or MWTs, and home sleep testing. Now, a diagnostic polysomnogram, as the name implies, it is used to diagnose a sleep disorder, for example, sleep-related breathing disorder, or parasomnia, or any other movement disorders, etc. But PAP titration polysomnogram is done when a patient is diagnosed with a obstructive sleep disorder or respiratory sleep-related breathing disorders, and the patient is coming back to see what exact pressure is required to um, alleviate or abolish the respiratory problems. And then this CPAP titration can also be done as on the same night of the diagnostic study by making it as a split night, where the first half of the night is considered to be diagnostic part and the second part is considered to be the titration part. Um, so once, what are the things to be considered before titration study? We have to educate about the disease, discuss the PSG results with the patient, explain what all things is expected to happen that night, discuss the treatment benefits, and then proper interface selection. Mask selection is one of the most important aspects, and the proper mask fit. We know that we have different types of the mask available. This is the nasal varieties, and this too is otherwise called as a pillows. This is nasal pillow. This is under the nose pillows, and this is oronasal masks. This is the hybrid version, there is no pressure on the nasal bridge. And lastly, this is the total face mask covering entire area of the face. Which mask to use during the titration study is basically patient convenience. Most of the time, what we see is that it is historically the treatment is called as a nasal CPAP titration, nasal CPAP treatment, and hence the mask, the better choice of mask is nasal mask. But there is no harm in using any of these masks if based on the patient's convenience. So how we do a sleep studies? Now we need to connect exactly similar to the diagnostic PSG. We will connect the EEG, ECG, EMGs, EOGs, respiratory effort belts, etc. During the diagnostic study, you can see that there is a nasal oronasal pressure transducer or an thermistor, which is used to measure the flow of the air. But in titration study, it will not be used, and we will be utilizing the oronasal mask or a nasal mask according to the patient, and the patient flow is detected from the CPAP mask. So how will be the montage? You can see here there is EEGs, chin EMGs, ECGs, leg movements, and the SpO2. But the flow, there is no thermal or a pressure transducer flow, but it is being replaced by the CPAP flow. It is the flow directly measured from the CPAP, and then the effort. You can see that the CPAP pressure is seen here. In this case, it is a CPAP of 10, and then total leak is also measured here. Lastly, you can see the patient's pulse rate as well. So, so if you are not using the pressure cannula or the transducer or the thermal sensors, you may be wondering how we will score the respiratory events. According to the ICSD, and ASM scoring manual version 3 and the previous versions as well, mentions that you can score the apnea based on the PAP device flow if you are doing a titration study. And the same thing for the hypopnea, either if you're using 1A or 1B, the same thing, PAP device flow if you're doing a CPAP titration. We don't need to use the thermal or pressure transducer. So what is titration? So in simple, you start a CPAP and gradually increasing the pressure until based on the respiratory events you notice until abolishing all the respiratory events. That is what is the titration guideline or titration all about. So how you do that? According to the guidelines published in Practice Parameters Guideline published by Kushida et al. In 2008 in some Journal of Clinical Sleep Medicine, the CPAP titration algorithm for the adult, that means more than 12 years, says like this. So you start at a CPAP pressure of 4 or a 5, and then you gradually increase it either by 1 centimeter or 2 centimeter. If you see any of these events, what are they? Events includes 2 obstructive apneas or 3 hypopneas or 5 RARA or 3 minutes of loud snoring. This is the guideline saying. 4, you have to wait at least 5 minutes. Again, it is a minimum time, not a maximum time. If you think that it is a minimum time, you will be end up increasing the pressure too fast. So what it means that once the patient starts sleeping, you started a CPAP of 4 or a 5, and then if you see 2 obstructive apneas within 5 minutes or 5 or 10 minutes, uh, or 3 hypopneas or more, or a 5 RARAs or more, you can increase to next level, that is 6, CPAP of 6. Then wait for 5 minutes minimum and see whether there is any obstructive events or hypopneas or auroras are coming. If you see it again, you increase it until you see there is no event for around 30 minutes. So, for example, you might be starting as a CPAP for a patient at a CPAP of 5, and then you end up in 6, 7, 8, and then you don't see any more respiratory events. You just wait there. You don't have to do anything else. Just observe and monitor until if you see another further respiratory events are seen later, then you might have to increase. If not, you can keep it at 8 itself, for example. Then there is an option for an exploratory purpose for up to 5 centimeter, and then there is a down titration guidelines also. But if you reach it to a CPAP of 15 or more, you need a more. The respiratory events are not controlled. Even with a CPAP of 15, you may transition it into BiPAP. Okay, so this is what is the nutshell of the CPAP titration guideline. Now, so upward titration at 1 centimeter increment for over 5 minutes period is continued according to the breathing events observed until 30 minutes without breathing events is achieved. Okay, if there is no breathing events in 30 minutes, then you can stop there. I mean, you stop titration, but not stopping the study. Let the patient continue sleeping at that level of pressure. A higher starting pressure may be selected for patients with elevated BMI or for those patients coming for a retitration studies. A patient having a high BMI, you might have seen patients saying that even at a CPAP pressure of 4, the patient is feeling too much pressure, which in fact may be the patient is feeling suffocated due to insufficient pressure. Maybe gradually increasing the pressure would help him to tolerate the CPAP. Or in the case if the patient is using, for example, he is already on a CPAP of 12 and the patient is complaining of excessive daytime sleepiness, and doctor want to see what's going on with a repeat study. You don't have to start from the 4. You can start at CPAP of 12 or 1 to 2 centimeter down and then see what is going on and gradually titrate it. So the higher starting CPAP pressure may be acceptable for those patients with high BMI and for those for coming for titration studies. Patient should be tried to BiPAP if the patient is uncomfortable or intolerant of high CPAP, which we'll be discussing down. So, what is the CPAP titration guidelines for the children less than 12 years of age? It is more or less the same thing. You start at the minimal CPAP pressure and wait for 5 minutes, and you are increasing the pressures based on this event. That is one obstructive apnea, one hypopnea, or three RRs, or 1 minute loud snoring, which is 1131. For the adult, it is 2353. And the rest everything is similar. They also recommend transitioning into BiPAP if the events are not under control with the CPAP of 15. So in short, what we have discussed so far is those patients, adult patients, age of 12 or more, the minimum CPAP is 4 and the maximum is 20. For those less than 12 is minimum CPAP is 4 and maximum CPAP is 15. Increase the pressure by a minimum of 1 centimeter with an interval of no less than 5 minutes when you see following events. For the adult patients, 2, 3, 5, 3, 2 obstructive apneas, 3 obstructive hypopneas, 5 RRs, 3 minutes of loud snoring. And for the pediatrics, 1131. So, what is the general titration rules? The patient must be asleep for increasing the pressure, except for those patient who is having high BMI and you needed to try a little bit of high pressure. Other than that, generally speaking, patient pressure should be increased only when the patient is asleep. The patient must be able to sleep in order for the titration to become successful, because the whole purpose of the titration is to see um, the obstructive events, respiratory events during sleep. So, patient needs to sleep to become the titration successful. If the patient awakens and complains of high pressure, the pressure can be reduced to a tolerable level. For example, you are in a CPAP titration study and the patient woke up at a, CPAP of 10 and he wanted to go to the restroom break. When he come back and he cannot sleep because the pressure is too high, you can reduce to a tolerable level. For example, he was okay with the CPAP of 6. You can start at there, and once the patient starts sleeping, you can go um, fastly to the previous level. In our example, to the CPAP 10. You don't have to wait again those respiratory even to gradually go to a 10. You can immediately go to that level. Patient with a higher body mass index may need to have a CPAP pressure started at higher pressure. And another thing is the leak should be addressed appropriately. So, based on the titration done and the success of the titration, it has been classified into four. What is the optimal titration as a good titration, or a good acceptable or unacceptable titrations? So what is this? An optimal titration is that when respiratory disturbance RDI is less than 5 per hour for a period of at least 15 minutes at the selected pressure and within the manufacturer's acceptable legal limit. The SpO2 is above 90% at that selected pressure, and there is a supine REM sleep, which is not continually interrupted by the spontaneous arousal for awakening. So, in short, if you have your AHI less than 5 with a supine REM sleep, uninterrupted supine REM sleep, with a saturation above 90%, that is called as an optimal CPAP titration. Then what is good titration? The RDI is less than 10 per hour, and which is more than 5 per hour, and it is less than 10 per hour, or if it is reduced to 50%, if the baseline RDI was less than 15 for a period of at least 15 minutes at a selected pressure, and the SpO2 is above 90%. Supine REM sleep is also obtained, and uninterrupted supine REM sleep also. This is otherwise called as a good titration. Here the AHI, in the optimal AHI was less than 5, here it is less than 10. Then adequate titration. The adequate titration here, the RDI is not less than 10 per hour, but the RDA is reduced by 70%, 75% from the baseline. Criteria for optimal CPAP or a good titration is not met because there is no supine REM, some supine REM sleep at that selected pressure. Then you will call it as an adequate titration. So unacceptable titration means none of the above are met. So repeat titration should be considered in an unacceptable, and in some cases for an adequate titration also. Sometimes physicians may say that. So let's go and review a CPAP titration study to see how it is done in real world. So here is the study. Here you can see that a CPAP study is being recorded, which says that CPAP started at 4 cmH2 medium nasal mask humidifier to lights out. Lights out is here the epoch number 23. This at the time of 11:24, something like that time. Patient was already asleep. The technicians couldn't do the physiological calibration, but they already did the mechanical calibrations, impedance check, and all those technicalities. Now he's the lights out stage, and you can see that patient is already asleep, and the frequent respiratory events are being noted. Obstructive events are being seen here. Now let's go to this is the first 2 minutes. Let's go to the next 2 minutes. So the same thing is continuing. Respiratory event, obstructive respiratory obstructive events are noted continuously. And this is almost the 6th minute into the study. And at 8 minutes, you can see that the events are increasing. The duration is increasing. And so what you can do now, it's already now it's 10 minutes. You can increase to the next level. Now you can see the patient is at the CPAP of 4, and as I mentioned earlier, you will be scoring from the CPAP flow channel, and you can see it's a clear no flow, which is in obstructive apnea. So now what is happening is that the technician, so far it's almost 36. That means almost 12 minutes is passed. The study started. Here the patient removed pulse oximeter probe tech inside the uh, patient room. So they went inside and connected back. And then you can see from here the tech increased CPAP to 6 centimeter for obstructive apneas. So now let's see what's happening. So let's go to the 6. So this is the CPAP of 6, 2 minutes. You can see again obstructive events continue. You have to wait at least 5 minutes to see the effect of that pressure. So let's wait for 5 minutes. Now this is the 2 minutes window. This is the second 2 minutes. That means almost 4 minutes passed now from the CPAP of 6. The obstructive events continuously is appearing, obstructive apneas, with the severe desaturations from 97 to 77, 95 to 77, etc. What you can do right now, so it is almost 8 minutes past in CPAP of 6. Now it is 10th minute. At the 10th minute, the technician increased CPAP to 8 centimeter. So you can see this is 7 and this is 8. Now from here, this is the 2 minutes window. Let's observe again for minimum 5 minutes. That's not maximum time. I repeat, 5 minutes is not the maximum time. You don't have to increase every 5 minutes. You can wait for a few more minutes, especially if you're a newbie. Wait for 10 to 15 minutes, then you will get a clear picture of what is happening to the patient. Now let's review the 2 minutes on CPAP of 8, 4th minute on CPAP of 8, frequent continuous obstructive events. But now the desaturations severity is reduced. Previously it was like something going to 70s, now it is going to high 80s only. Let's see what's going on. Now it is almost 8 minutes. Now it is the 10th minute. Now, around 12th minute, the CPAP is increased to 10 cm for obstructive apneas and desaturation. So now you can see here the CPAP pressure is increasing into 10 cm now. So here the technicians used 2 centimeter every increment. But if you are a newbie again, I would suggest you to start increment at a CPAP 1 centimeter. You can increase a 2 centimeter pressure if this event is very severe, as in this patient, or also during the initial stage, like CPAP 4 to 6 and 6 to 8, like that. But 4 to 8 is considered to be the low CPAP pressures. 8 to 12 is considered to be almost a medium level of CPAP pressure. And if you take, generally speaking, most of the patients will be something between 8 to 12. And more than 12 is considered to be high CPAP pressure. So from 8 onward, you may increase only one pressure for better CPAP titrations. So CPAP titration means the minimal pressure required to abolish all the respiratory events. So here the technician increased to 10 centimeter. Here, let's see what is happening to the patient. So this is the first 2 minutes. Now you can see the previously you can see that clear obstructive apneas was there. The moment the patient in the pressure is increased to 10 centimeter, the obstruction is resolved and hypopnea is coming. There is still some obstructive component, but it is getting much better. And now see there is this is classic hypopneas from and here as well these arousals and desaturations. Now the patient, it is almost 5 minutes. You can see that there is a hypopnea here. From here onward, even though the patient is at a CPAP 10, the flow is getting better and the events are under control. So now you can see that when the patient increased, the pressure is increased to 10, it took almost 5 minutes to get that effect to see it in our study. So that's why we are saying always wait for a few minutes, minimum 5 to 10 minutes. Now here, let's see CPAP of 10, the respiratory events are under control, saturation is well above 95, sleep stage is looking to be in N3, even though you cannot view it in the 2 minute window, it appears to be in N3 pattern. Um, let's see, move forward every 2 minutes. Now you can see the REM sleep is the eye movement and the patient is in REM sleep, and you can see that there is some short or small central apnea pattern which usually seen in the phasic REM sleep. And even though there was some slight desaturation 94 to 91, possibly a hypopnea central in nature, but in generally speaking, patient is doing very well. CPAP of 10, and that's all. And he's having REM sleep. Let's see what is the stage of the position of the patient. Here we can see that the patient is in position. Here the patient is in supine REM sleep with events under control. Uh, Later, the technician increased to 12 for hypopnea desaturation. That was the one which we observed only during that transition phase from 8 to 10. Generally speaking, we could have waited few more minutes and observed. But again, you can see they just increased for an exploratory purpose or something like that. If you go to the trend, you can see here there is this is the SpO2, this is the sleep stage levels, and this is the respiratory events. Even though we haven't, no, we haven't. The respiratory events is here. We haven't scored the respiratory event for the sake of showing you the events. There is a continuous desaturation caused by the frequent apneas and hypopneas. This is the starting pressure, CPAP 4, 6, 8, and 10. From 10 onward, you can see that SpO2 became well above 95 or stabilized. And you can see a couple of dips here and there. And at this level of supine sleep we had during the towards the end of the night, there were some couple of events for which the technician increased to CPAP of 13. And every event is under control. This patient had very severe diagnostic study, which means that AHI was 60 plus. The low saturation noted was 65 or something like that, and then the patient spent his oxygenation level below 90 percentage for more than 25% of the total sleep time. So it was very severe study in terms of the AHI, severe in terms of the hypoxemia, and he is having very severe excessive daytime sleepiness, as mentioned by a sleepiness score of 20 or more. So this patient study, you can see that it's well controlled with a CPAP of 13. Now, if you apply the type of the titration, is it an optimal, good, adequate, or inadequate? You can see that the patient had a supine REM sleep, uninterrupted REM sleep, and there is the so-called almost REM sleep is almost 30 to 40 percentage of the time as well. Now, let's review another study. This was a overnight titration, CPAP titration from the beginning itself. Now, let's do a split titration study. Here you can see that at the beginning of the study, there is a frequent desaturation owing to uh, respiratory events. You can see obstructive component, obstructive apnea throughout the study. Let's see obstructive apneas and mixed apneas, obstructive apnea with the paradoxical breathing, desaturations, and so forth. So in the middle of the night, after the 2 hours, as per the lab protocol, we started the CPAP. CPAP is mentioned here, IPAP and EPAP. You can see they started at the CPAP of 4 and they jumped to 6, 8, 9. Then the events become under control, and from here onward it was a CPAP of 10. Everything was under control. Now let's look at the therapeutic version. So now here, let's go to the 2 minutes. Yes, see, you can see the path flow. It is the CPAP flow. Everything looks well controlled. So this is an example of split night study, and the one previously mentioned was an overnight full night titration study. So this is how we do in sleep lab. Let's go back to our slides. So next, so what we have seen in the both overnight titration and the split night study is that what is a continuum of obstructive events? Here you can see this is the normal breathing. There is no snoring, or the effort, the flow is available for each effort. Saturation is well maintained. As you start gaining the weight, you may start having some snoring, but the flow becomes everything normal. And you didn't do anything about that, and you started gaining the weight or increasing the age, it may become the hypopnea, reduced flow, causing a desaturations. And even at that time, you didn't do anything. There would be, it may end up in obstructive event. So this is a continuum as you go this way. But once you start adding a CPAP, it goes in the opposite direction, as you've seen in that patient. So obstructive events become hypopnea and then gradually becomes normal breathing pattern. So the uh, the pattern goes in this direction in the severity of obstructive sleep apnea, and when you start CPAP, it goes in this direction. Let's look into what is happening with BiPAP, bilevel titration. So, bilevel titration studies. There are two types of bilevel titration studies. As we see, if the respiratory events are not under control with a CPAP of 15, we may transition into bilevel studies or a direct bilevel titration studies. So, where you will go to a bilevel direct bilevel titration studies. It may depends on the patient's condition. If the patient is having a obstructive sleep apnea associated with comorbid conditions like COPD, hypercarbia, obesity hypoventilation syndrome to some extent, or those patients with neuromuscular disorders, or the patient is having suspected chain stroke respiration or cardiac failure, something like that. So any patients having comorbid conditions, the doctor may tell you to go with the direct bilevel titration. Or otherwise, you may be starting at a CPAP titration, and if the events are not under control, even at a pressure of CPAP of 15, or if the patient is not tolerating the CPAP, you may transition into bilevel. In either case, from CPAP to bilevel or a direct bilevel titration, the protocols remains the same. So, what is a bilevel device? As you being a respiratory therapist, you better know what are these, and you are daily using it in the critical care areas or acute care flows. It has got two levels of pressures: IPAP, which is inspiratory positive airway pressure; EPAP, which is expiratory airway positive pressure. For the sleep studies, titration is concerned, the minimum pressure is IPAP and EPAP is 8/4. Minimal difference between the IPAP and EPAP is the 4 centimeter, which is otherwise called the delta P, or the pressure difference. And the maximum pressure difference between the IPAP and EPAP is 10 centimeter. There are different types of the modes. We know that is a spontaneous mode, ST modes, T modes, etc. But we will be discussing only the basic titration guidelines within this topic. Um, what is the BiPAP titration guidelines for the patients more than 12 centimeters of years, the adult patients? From the same guidelines which we discussed in the ASM practice parameters, it is also the same thing. Here we will be starting at a minimum pressure of 8/4 if it is a direct BiPAP titration, so the bilevel titration. And the both IPAP and EPAP are increased for apneas for 1 centimeter for the events as mentioned here. It is again, the mnemonics is 2, 3, 5, 3, 2 obstructive apneas, 3 hypopneas, 5 RRs, and 3 loud snoring. Here there is a slight difference because we have to increase two levels of pressure. You have to increase IPAP and EPAP or both. So if you see an obstructive event, you will increase both IPAP and EPAP of 1 centimeter or more. If you see two obstructive apneas, you increase IPAP and EPAP at the same time to make the pressure difference same. But if you see three hypopnea, the hypopneas are aroused and loud snoring, you will increase only IPAP. You will keep the EPAP as it is without touching. And so here it is written here, IPAP and EPAP for apneas and IPAP alone for other events, which is hypopneas, RAVAS, and snoring. Again, there is an exploratory purpose titration. Exploration purpose pressure increment can be given up to 5 centimeter, and then there is also down titration policies as well. And so now there is a difference. This is the one which we discussed is 8. We are starting at 8/4. But what if the patient, if the a patient was on a CPAP titration and getting transitioned into bilevel? So in that case, what should be the starting bilevel pressure? So the EPAP should be the pressure which abolished the CPAP level, which abolished the obstructive apneas. So in the case which we discussed earlier, the CPAP titration study where the obstruction were under control with the CPAP of 10. So for that patient, if that patient were uh, transitioning into a bilevel, we will be keeping an EPAP of 10 to begin with, and then the IPAP like 5 or 15 or 16. Based on the pressure difference between the two is being determined by the tidal volume based on the ideal patient's body weight. The optimum minimum IPAP EPAP, the minimal IPAP EPAP difference is 4 and the maximum difference is 10, as we discussed earlier. The same guideline is given for the pediatric as well. Again, 1131. You increase IPAP and EPAP for obstructive events and IPAP alone for the rest of the events like hypopnea, arousal, and snoring. So in short, what we discussed so far is for the adult greater than 12 years of age, the minimum IPAP is 8 and EPAP is 4. The maximum IPAP is 30. Minimum IE difference is 4 and the maximum IPAP EPAP difference is 10. So in this case, it can be if you're expecting a worst patient scenario, you may be having 30 over 20 or 30 over 26 with a minimum of 4. And the similar is applicable here for the less than 12 years of age. Here the maximum IPAP is 20 and rest everything remains the same. Increase both IPAP and EPAP pressure by minimum of 1 centimeter with an interval of no less than 5 minutes when you see 2 obstructive apneas and 1 obstructive apnea in children. And you increase the IPAP alone for the 3 hypopneas, arousal and loud snoring. So optimal, as we discussed earlier, optimal titration, good titration, adequate titration, and unacceptable titration also same with the bilevel titration study. Now let's go for a BiPAP titration study. Here the study started and the sleep onset is at an 8/4. This is the case, and you can see that it's a 2-minute window, and there is seep flow you can see, or you can see that obstructive events are seen. And what you will do next, this is only a 2-minute, and you will wait for minimum of 5 minutes, and you can wait for a few more minutes like 5 to 10 minutes or 15 minutes, no problem, but you have to wait. And then you see after a few minutes what you will do, you increase the IPAP and EPAP because this is obstructive events, so you have to increase both. So minimum by 1 centimeter. So what you can do now, it is already at 8/4. What you can do is you increase to 9/5. Again, the you waited for some minutes, and then you continuously seeing the same events, obstructive events. What you will do next? You wait for the same thing. Wait for at least 5 minutes and increase the IPAP and EPAP together because you are seeing the obstructive events. So now you were 9/5. Now you will go to 10/6. Now you are at a pressure of 10/6 and you're seeing this type of event for the next couple of 2 minutes. This is an hypopnea causing a desaturation from 96 to 91 and then arousal as well. So now you're seeing hypopnea. So what you will do next, if you have already waited for more than 5 minutes or 10 minutes, let's say, what you will do next? In that case, do you have to increase IPAP and EPAP, or IPAP alone or EPAP alone? What you will do? Yes, you will be increasing only IPAP because it is hypopnea. So now you were on a 10/6, you will be increasing to 11/6. Now you can see the IPAP have increased, and so is the pressure difference between IPAP and EPAP. So the patient continues to have hypopneas, arousal, snoring, even on a pressure of 11/6. What you will do? You will continue and observe for a few more minutes, and then what you will do is you will increase only IPAP. We can see now the BiPAP increase the IPAP, and the BiPAP now it will become 12/6. Sorry for the, I think you may not be able to see the bottom line here. But it is 12/6. Now, the patient is currently on 12 over 6 and he is having nice breathing. Saturation is well maintained about 98, 97 percentage. No respiratory events. There is no arousals. Patient appears to be in 2 or either stage 3. What you will do next? You just observe, monitor. You have nothing to do now because the patient is respiratory events are under control. Let's see now here the hypopnea returns. Here you can see that the hypopnea is here causing desaturations and same. Why it could be? You can see that the eye movements are coming. It may be difficult to find out with as it is in the 2 minutes window, but the patient is transitioning into REM sleep. We know that REM sleep is the worst for the respiratory events, and supine REM sleep is the worst position for having a respiratory event. So the patient is entering into REM sleep, and that may be the reason why the patient is having hypopnea. He was doing very good at a 12 over 6. What you will do next? So patient is already on 12 over 6. So you will increase only IPAP because it is again, it's only hypopnea. So it is just like 13 over 6 now. And obstructive and snoring are eliminated 13 over 6, and supine REM sleep patient is tolerating and patient is having very good REM sleep without any respiratory events. What you will do, you just observe and monitor. So this is how you do a bilevel titration studies. Now what we have discussed in a nutshell is that you increase IPAP and EPAP for obstructive apnea, and you increase IPAP alone for hypopnea, snoring, and REM. There is no standard protocol for the PAP. These are the guidelines. Titration guidelines should be same for the overnight titration should be the same for the split night and full night titration studies. Optimal PAP pressure is achieved when the apnea hypopnea index, including the supine REM sleep, is less than 5. Patient should be acclimatized to a PAP therapy with a mask before the sleep study begins, especially in the case of split night study. In the middle of the night, you start CPAP and the pressure is been already been applied. The patient may get afraid, so hence you might need to explain to the patient ahead of time. So there are some additional considerations. Optimal PAP is defined as the highest pressure achieved during REM sleep while the patient sleeps in the supine position. Okay. If the patient is in REM sleep but not in the supine position at the final pressure, consider instructing the patient to lie in the supine position. So to get optimal titration results, we need to have a supine and REM sleep. Sometimes patient may not be able to sleep on the supine, for example, due to his back conditions or something like that. He may not be able to, and we may not be able to get a optimal titrations. But if possible, you can make the patient lie in supine. The optimal PAP level in the supine position is typically higher than the optimal PAP needed while sleeping in the lateral position, regardless of the obesity and age. Usually, it is like 1 to 2 centimeter higher. Um, so sometimes during the titration studies, you may need to add an supplemental oxygen. Supplemental oxygen should be added during a PAP titration studies when prior to the PAP titration, the patient's awake supine SpO2 while breathing is 88%, or supplemental O2 may also be added during the PAP titration when SpO2 is less than 88% for more than 5 minutes in the absence of obstructive respiratory. So now you are doing a titration studies. You increase the CPAP pressure, and you reach the CPAP of 12, and there is a supine REM sleep. There is no obstructive event. There is no hypopnea. There is nothing. The only thing you notice is the oxygenation drop. It is well below 88, and it's sustained desaturation. You can increase the pressure a little bit more for an exploratory purpose, and if it didn't work out, you may add an oxygen. So, what is the guideline says? Guideline says you can add supplemental oxygen if the SpO2 is below 88 percentage for more than 5 minutes, sustained drop, not desaturation and resaturation pattern. It's a sustained desaturation. In both instances, supplemental O2 should be introduced at a 1 liter per minute and titrated upward to achieve a target SpO2 between 88 and 94. Some centers may just need only 90 above saturation level, and we know that we don't need 100% saturation by adding an oxygen, and we need to be cautious of giving more oxygen to certain patients. So how you add? So you can add by using the TPs or Hudson TPs here, where you will connect the TPs. You just need to connect at the uh, outlet of the machine, not at the mask level. Why? Because a mask already have an exhalation port. When you add oxygenation, it may not get blended with the air, it may washed out through the exhalation port. So, and hence, it is better to add the oxygen at the machine's outlet as shown in this picture, and the tube will be directly connected to the mask. Other modes of ventilations are there. For example, adaptive servo ventilation may be considered if the patient is observed to have the chain stroke respiration, or if the patient is having a treatment emergent central sleep apnea, or otherwise called as the complex sleep apnea. For example, you were doing a diagnostic study where the patient is exhibiting predominantly obstructive apneas, and once you started a CPAP, the patient is now showing the central apnea. This is what is always called as a complex sleep apnea. Or the patient is having chain stroke respiration, as you see in the crescendo decrescendo pattern with the central apnea in between. Uh, Things like that we use adaptive servo ventilation, or an AVAPS, average volume assured pressure support ventilation in the case of hypoventilation cases, or those patients who is having hypercapnia, or those type of patients or neuromuscular disorders. Example, we may use that. I'm just giving you a word. There are other modes of ventilation like ASV, AVATS, titration guidelines for the hypoventilation syndromes, which is entirely a different topic and needs a special attention in detail, which we will be discussing later. So far, what we have discussed is the CPAP titration guidelines, and we also saw how we can apply it in the real practice, the real world, by seeing a titration study, overnight titration, and a split night titration studies. And we also discussed some aspects of the bilevel titrations. If you have any questions, feel free to ask. And these are some of my references which I use to prepare for this talk. Thank you. Thank you for watching.